I'm Dr. Ken Landau. Thanks for watching. This is Well Now Doctor. We're talking about osteoporosis and specifically the treatment for osteoporosis. Well, as we've said before, a lot of people have osteoporosis. Estimated that the number in the United States is in excess of 10 million, 8 million women, 2 million men. We have a condition where the bone is a little bit reduced in mass, but not quite as much as the diagnosis of osteoporosis entails. Those people account for another 18 million at least. That's called osteopenia. Question is it real disease or not? But we do know that when we look at fractures, and fractures are caused not by the osteoporosis, fractures are caused typically by falls or some kind of trauma to the bone. In the case of your backbone, it might be you lifted a heavy object, you didn't bend your knees, you carried too heavy load on your back, you were lifting a suitcase or moving a chair, and that might have been enough. We know that if you look overall at osteoporosis, it's a risk factor. It has to be changed into an actual fracture by something, and the something is typically trauma. So it's a risk factor. It's a risk factor just like high blood pressure is a risk factor for a heart attack. Elevated cholesterol is a risk factor for hardening of the arteries. Being too fat is a risk factor for diabetes. But just because you have an elevated cholesterol doesn't mean you need a drug. Just because you happen to have too much body fat doesn't necessarily mean you're going to get diabetes. So what we know is it's a risk factor that in large measure is determined, 1, by your genes, 2, by your genes, and 3, by your genes. Your genes actually account for about 70 to 80% of your bone mass. Only about 20% has to do with environmental circumstances. We do know, however, that if you get enough exercise, if you get enough calcium when you're young, and by young I mean prepubertal throughout the teenage years, then you build up strong enough bone. Once you get beyond age 30, chances are you're not going to develop extra bone by exercising. You might reduce the likelihood that you're going to fall, and that's very good, and that's to be recommended, of course, but you exercise not because you're building up your bone. You take the calcium for reasons that we don't really know, because the calcium, for the overwhelming majority of people, doesn't seem to do all that much, doesn't seem to prevent osteoporosis. So back to the subject. Osteoporosis is a risk factor. It's a risk factor. It is not a disease per se. It's just a risk factor. And the major issue we have is falls. Falls. We don't have any medicine, by the way, to reduce the likelihood of falling. We do know that if we measure people's bone density, that can give us a rough estimate of whether the people are likely to have fractures or not, but only on a societal basis in large numbers of people. If we're looking at an individual per se, a person, well, knowing what their bone density is isn't really going to tell us whether that individual is going to go on to develop a fracture. And there's accumulating evidence that the World Health Organization's assumption that osteoporosis is the cause of fractures in the elderly population probably is wrong. So how do we go about looking at this condition? Well, first of all, treatment is looking at the kind of medicines you're already taking for other things and getting rid of unnecessary drugs. So look at the medicines and say, is the medicine necessary? Or how about a lower dose? And if you're a cigarette smoker, we know that cigarettes are directly toxic to the osteoblast, directly toxic to your ability to form bone. So cigarettes are bad. Cigarettes cause lots of problems. Alcohol leads to falls. Orthostatic hypotension. You're taking too much medicine for high blood pressure. In fact, you're taking so much medicine, your blood pressure is now too low rather than too high. Or maybe you're taking a diuretic. Maybe you're getting up at night to urinate. Well, when you stand up at night, especially when you're in a nice warm bed and comfortable, you stand up, your blood pressure falls down, and so do you. And then you fracture your hip. That's very important. Sedatives and hypnotics. Well, they might be okay if you're 50 years old or 40 years old or 30 years old if you have an anxiety-related issue. But if you can't sleep and you happen to be 80 years old, or if you're under a little bit of agitation, chances are those drugs are not really for you. Chances are those drugs can cause more problems. Chances are that they'll make you fall or slip or have some sort of a traumatic episode that leads to a fracture. And we have to be a little bit careful of our environment. We know that exposed wires or frayed carpet on the stairs or slippery floors, or even having a dog or a cat that takes an object and puts it in the floor and you step on it at night, that can increase your risk of problems. And you certainly don't want to walk around in stocking feet, especially if you have wood floors. You have to make sure that there's good light on the pathway to the bathroom, because so many of us get up at night to urinate, and if you get up to urinate and you misstep, you may fall. You break your hip. Impaired vision is a very important issue. So if you get up at night, well, put your glasses on. Don't go to the restroom without your glasses. You have to be able to see. And if you have a neurologic condition, you have to be extra cautious. If you have Parkinson's disease, high tendency of falling. Or if you have Alzheimer's disease, or if you have multiple sclerosis. And we know that there's some simple tests that we like to do. Simple tests for most people with osteoporosis. We check the blood count, make sure that there aren't any significant abnormalities, check the amount of urine calcium, check the amount of serum calcium. We like to check the liver and the kidneys, make sure they're working appropriately, because we know if they're not, chances are you're going to have some problems with your bone. Check the amount of inflammation through a simple blood test called a SED rate. We check the vitamin D, we check the thyroid hormone, all of those relatively simple and give us some good information. If you have too much calcium in your blood, well, you might have too much parathyroid hormone. You might have a tumor of the parathyroid hormones. Not an uncommon condition, or even more likely, especially when we're talking about people who are 70, 80, 85 years of age, tumors. Tumors can attack the bone, and when they attack the bone, they dissolve the bone, they put the calcium into the urine, into the blood, and in doing so, they make the bone more fragile. They make you susceptible to a fracture. So we want to check that. Now, if we check the urine, we can check the urine for calcium. That's relatively easy. If there's too little, there's a problem that you're not absorbing it. And if you have too much, there's a problem with either it's coming from the bone or you're taking it in and it's passing right on out. Now, there are certain kind of diseases that we want to at least consider. A disease like Cushing Syndrome, where you're making too much cortisone. Remember, we said cortisone, prednisone is a drug that can increase the likelihood of osteoporotic fractures. Well, your body can make too much cortisone. That's called Cushing's disease. Or maybe you have some sort of a bowel abnormality. If you have malnutrition, then maybe you don't have enough calcium in your system, and that can lead to osteoporosis. Maybe all the calcium goes out through your gut. Maybe you have celiac disease. Maybe you can't absorb it. Maybe you have myeloma. That's a tumor that can affect the bones. Used to be we would even do bone biopsies sometime. There are biomarkers that can be evaluated. These are blood tests, and blood tests can give us an idea of what's happening, especially when we're beginning a course of therapy. We've said before that if we look at the DEXA scans are going to take a long time, several years, to show any significant change. The bone markers show change much more rapidly, and it all depends on what kind of medicines that we're using. So if we're using Forteo, which is a parathyroid-like hormone, well, we're going to see significant change relatively soon. On the other hand, if we're using a drug maybe like Avista or Raloxifene, not going to see too much change too quickly. Now, there's a problem with the treatment of osteoporosis, and the treatment, unfortunately, seems to get high marks by the drug industry, and unfortunately, there's a little bit of a conflict of interest, and we all have to be a little bit skeptical about what we see, what we hear, what we read, and unfortunately, in the case of therapy for osteoporosis, we know that most of the investigators, at least 50% of the investigators, seem to have some conflict of interest because they're receiving some funding from the pharmaceutical industry, or their departments are, or somehow they're getting some amount of money, and that might cause a conflict of interest. And we know that if you look at what we really need to do, if you look at something that might be able to significantly improve your lot, it probably isn't a drug. It probably is a lifestyle modification. Go out and get some physical activity, stop the smoking, stop the drinking, do those sorts, make those sorts of changes, and they'll probably benefit your bones a heck of a lot more than simply treating what's called osteoporosis. We know that with all of the attention, all of those ads you see on the television, we've gone from sales of drugs and devices in the osteoporosis realm of about $300 million a year in 1996 to 2015, it's estimated that sales of these devices and these gadgets and these treatments are going to be well in excess of $11 billion. So it's big business. Now, there's some argument that treatment isn't a real viable option. It's not cost efficient. It causes psychological harm. We overdiagnose, we overuse our treatment, and unfortunately, part of this seems to be due to pressure from the pharmaceutical industry. Uncritical medical societies take on the mantle and believe in all sorts of interventions. They tend to look at devices more than clinical skills. We have a lot of money that can be made by telling healthy people that they're sick and having them take medicine when indeed they probably shouldn't. We call that disease mongering. It gnaws away at an individual's ability to psychologically be normal. We know that the pharmaceutical industry is instrumental in sponsoring conferences and talks and advertisements on the television. It promotes the disease. We have an informal alliance of doctors and staff and doctors and consumer groups. Ostensibly, they want to make us aware of conditions, all sorts of conditions. Just watch the television and you see so many of the ads for a variety of different drugs, and you wonder, what are we treating? Do we really need to treat all of these conditions? They promote the concept that illness can be widespread, and without their informing us, well, we wouldn't know that we had a disease. We would think that we're perfectly healthy. And why could we be perfectly healthy when we should be taking a drug, according to the drug companies? So they have all these disease awareness campaigns, and they're orchestrated by all sorts of public relations firms, and they target the mass media, as you see when you look at the television, you listen to the radio. They have payments, and they have media prizes and awards, and all this is going to lead to significant amount of economic waste and iatrogenic illness, doctor-caused illness, because we give people medicines, and when we give people medicines or do surgeries, then unfortunately what's going to happen is some people are going to have some side effects. We have poor decisions, we have unnecessary labeling of individuals. You walk into the doctor's office, feel perfectly well. Hey, Dr. Jones, how are you today? I feel perfectly well. Oh, you're not well. You've got osteoporosis. You have a variety of other conditions. And then all of a sudden, we're going to divert the resources from areas where there is true need, and now we're going to be taking a lot of drugs that we perhaps don't need, and we're going to focus on drugs rather than lifestyle modifications, kind of like with diabetes. How often are people successful at losing weight? How often do people go on a regimen of exercise? Well, unfortunately, it's relatively small. And same thing with osteoporosis. We don't promote doing certain things. We promote taking drugs. And all of this is going to threaten the viability of the insurance industry here in the United States. Now, we don't really have any major love for the insurance industry, but they have to be able to protect all of us. And if we're taking medicines that are unnecessary, and just as an example of an expensive medicine, there's Forteo, and Forteo costs $2,000 a month, and you have to take that for 2 years. That's a significant burden. Well, could there be some other better use for the medicine? And that's the question that we always have to answer. Risk versus benefit, need versus want. Well, that's a significant issue. We have all sorts of conditions that are being promoted, from social phobia, attention deficit disorder, irritable bowel syndrome. Some of these real, some of these not. Well, what's the treatment for osteoporosis? Well, if you have an osteoporotic fracture, and you have an osteoporotic fracture of your hip, obviously go to the hospital, go get an operation. And if you do that and get some rehabilitation, then chances are you're going to be better. But as we said before, you can have significant complications and side effects, especially if you happen to be otherwise sick. If you're in a nursing home and then fracture a hip, or if you're 85 years old and you fracture a hip, hey, you're at considerably increased risk compared to a person who happens to be 50 or 60 years of age. If you happen to fracture a long bone, go get a cast, go get some sort of stabilization, internal, external. That's probably going to be adequate. Not all osteoporotic fractures need any kind of therapy. So for instance, if you fracture your vertebrae, either in your chest or behind your belly, well, chances are not going to need any kind of therapy. You might need a pain medicine, but oftentimes, at least with vertebral fractures, you don't even know that you have a fracture. Only about 1/3 of the vertebral fractures are symptomatic. We know you can have a rib fracture, you can have a pelvic fracture. All of those may be some general support, but certainly no orthopedic intervention for the overwhelming majority of people. The idea that you need treatment varies with the location of the individual, what country you happen to be in, and where the fracture happens to be, the severity of the condition, what's your general health. All of those are very important. Now, we said that about 1/3 of the people with fracture of the backbone need some kind of therapy for the pain, and that can be an analgesic. Typically it could be a warm compress, it could be an aspirin or an aspirin-like substance, or it could be a Tylenol. Maybe we treat the muscle spasm with some ultrasound or some TENS unit, anything just to get over the initial 4 to 6 or 8 or 10-week period during which you have the pain. Some people believe in using injections of a substance to fill out the vertebrae. We call this either Kyphoplasty or vertebroplasty. People argue about whether they're really worth it, whether they have more complications or more benefits. And if you have low back pain, well, if it's due to a fracture, chances are it's going to go away relatively quickly. A lot of people have low back pain without any relation to fractures, and in those people it might be a muscle, a ligament, might be a tendon, might have some secondary arthritis. Well, all of those issues need to be considered. Not all back pain in people who have x-rays that even show osteoporosis or osteoporotic fracture, not all of those individuals need treatment for the osteoporotic fracture. Sometimes they just happen to be people with low back pain who also happen to have fractures. And we also know that if you do have a fracture, it can cause some psychological issues, change in the body configuration. It can lead to an altered self-image. Sometimes people are depressed, they stay indoors. Sometimes people are afraid of falling because as you fracture vertebrae, well, you can bend over, you can get what we call a kyphosis, and when you get the kyphosis, then you have to look up this way. That can hurt your neck, even though you don't have an osteoporotic fracture of your neck. It can cause pain just because you have to look up now, and as a result, it changes your center of gravity. When you do that, you have a tendency to fall even more. So, things to consider. Now, we know that there's this other condition. So we talk about the osteoporosis. We have some drugs for osteoporosis. Well, what about osteopenia? Osteopenia is a very controversial condition. It was created by a global alliance of doctors and drug companies and advocacy groups, and it's treated as a silent epidemic that affects tens of millions of individuals. But other people say, hey, we're disease mongering. We're trying to sell drugs and tests to otherwise healthy women who are told that they're really at risk of being at risk. It's not even a risk factor itself. It's just a risk factor for a risk factor. It's estimated that probably more than half of women who are postmenopausal have, by definition, osteopenia. In Europe, the drug companies are already trying to sell drugs for osteopenia. They actually had to be reprimanded in Spain, 2 companies, the Procter & Gamble and Lilly. According to the Spanish authorities, they were exceeding what was acceptable. We know that people talk about these major changes. You have a 50% reduced likelihood of having a fracture if you take this kind of drug, or a 75%, 50%, 40%. Well, 40% of what? So when we talk about all of these big numbers, they're relative decreases. So, for instance, with a drug called Avista, Avista is said to reduce the likelihood of fracture by about 75%. That sounds phenomenal. And you know something? If something's phenomenal, it's too good to be true. It's not true. So a 75% relative reduction works out to less than a 1% absolute reduction. So we have to be a little bit careful about some of the numbers that people talk about. Now we have therapies, we have drugs, we have lots of drugs. We have what are called anti-resorptive therapies. Most drugs are anti-resorptive. We only have one drug that stimulates formation of bone. So the anti-resorptive drugs, remember we said that you get a certain amount of bone density and then it gets resorbed as you get older. Well, we have drugs that prevent some of this resorption. And that's a good idea. So we have the bisphosphonates. And we have oral bisphosphonates, we have injectable bisphosphonates. Those are Fosamax and Actonel and Boniva, drugs like that. And then we have estrogen, the hormone replacement. Then we have the SERMs. Those are drugs like Nolvadex and Avista. In Europe, they have a drug called strontium. And strontium seems to be relatively good, just basically as good or lack of good as any of the drugs that we use here in the United States. We have the anabolic drug. We have the drug that actually stimulates bone formation. There's only one. It's called Forteo or Tairy Peptide. This is a drug that is an analog similar to parathyroid hormone. You can only take it for 2 years, phenomenally expensive. And then we have another drug that's called Prolia, and Prolia has a novel action. Prolia that you only have to take twice a year, and it's by injection underneath the surface of the skin. Prolia works to prevent the osteoclasts from getting activated. Now, the number necessary to treat, well, how many women do we have to treat to prevent one fracture? So if we look at women who are 50 years old, and if we look at their total hip bone mineral density, let's say they're in the osteoporotic range, they have a -3 standard deviations, remember 2.5 or more makes you osteoporotic. Well, those women over the course of 10 years have about a 2.8%, a little less than 3% likelihood that they're going to have a hip fracture. If we begin those women on some kind of therapy, we can reduce the likelihood of a hip fracture by 50%. But it's 50% of 2.8%. So now the likelihood that those women are going to have a hip fracture, if we follow them over 10 years, is going to be only 1.4%. Well, you could say it's a 50% reduction or it's a 1.4% reduction. We need to treat more than 70 women to succeed in preventing one hip fracture over 10 years. So 70 women treated every day for 10 years to prevent one woman from having a hip fracture. On the other hand, if we look at older women, same body mass, same bone density, -3. But the women, instead of being 50, now are going to be 75. Well, the likelihood that they're going to suffer some sort of fracture of the hip over 10 years, going to be about 18%, only about 9% on therapy. So now we only need 11 women to treat. But unfortunately, the drugs don't seem to work in older people. The drugs seem to work in younger people, the people who don't need it, the people who are unlikely to develop a fracture. Those are the ones in whom the therapy works. The women who are at risk, well, significant lack of effect. So what do? We look at the risk factors. Well, the risk factors, hey, stop smoking, get out, get active, go walk, go do something, and eat well, eat appropriately. Review the medicines that we talked about, get off the cigarettes, get off the alcohol, watch the sedatives, watch for the low blood pressure, keep the lights on, all those sort of things are extremely important. And watch out for a lack of or an impairment of some kind of body function. So your vision, your balance, your hearing, your strength, your gait, all of those need to be considered. And we know that people in nursing homes are at especially high risk. People who are in institutions, especially high risk, at risk for falling. We know that if we look at people who are 75 years of age or older, the likelihood of them falling in the course of a year is probably somewhere around 50%. And remember, that's how you translate osteoporosis to an osteoporotic fracture. And then we have to be a little bit cautious about our diet. You have to make sure you have enough calcium in, but we don't even know that the calcium that you take in is really going to do anything. But people say that calcium is important, and you can't really argue that you need some calcium. How much calcium, don't know. And best way to get your calcium is to get it through food. Go get it through some milk or some yogurt or some cheese. And maybe now some of the fortified foods like the cereals and the waffles and the snacks and the juices and the crackers almost have as much calcium as the milk. But not all calcium has the same bioavailability. Sometimes you take the pill and the pill goes all the way through, comes out the other end, and you don't get any calcium inside your bloodstream. So what you'd like to do, if there's a question, you go get a little cup of vinegar, put the calcium pill in there, let it sit in there for half an hour, and if it dissolves, then chances are it's going to dissolve inside your body. Now, you also have to realize that different kind of calcium have different requirements. So if you take calcium citrate, you can take that at any time. On the other hand, if you take calcium carbonate, which is the most common kind of calcium, you have to take that with food because it needs some acid in your stomach. But guess what? As you get older, you make less acid. You shouldn't take too much calcium at any given time, because if you take too much calcium, it's not going to be absorbed. So you want to take less than 600 milligrams of calcium at any given time. You could take it several times a day, but not all at once. And you have to consider, what is the elemental calcium? What's the concentration of elemental calcium inside the pill? And it's not necessarily what it says on the label. So for instance, if you take calcium citrate, it might say that it has 300 milligrams, but that's only 60 milligrams of calcium, of elemental calcium. You could take a Tums 500, that's got about 500 milligrams of calcium. There are a lot of very inexpensive calcium pills that you can take. Some of the side effects of calcium, well, if you take it, you could get some burping, some constipation, especially if you take the calcium carbonate. And if you have a tendency toward kidney stones, you might get some kidney stones. And now there are some reports that calcium can actually increase the risk of a cardiovascular event, a heart attack. So there's 6 extra heart attacks or strokes in every 1,000 people who take a calcium supplement for a year. So there might be some new added risk of taking some calcium. Vitamin D, well, you should take some vitamin D. You should get enough vitamin D in. We're not exactly sure what the vitamin D does, but some of it's important. But there's a lot of controversy about vitamin D. Go watch the show that we did several months ago. You can find it on this same area. And we talk all about vitamin D. Well, there are other nutrients. So if you take too much salt, and a lot of us take too much salt, then that's going to get some of the calcium to be urinated out. If you have too much animal protein, you're going to lose a lot of calcium. If you take some caffeine, you might lose a little bit. And if you happen to be taking warfarin, the blood thinner, well, that blood thinner is going to interfere with the carboxylation of a chemical known as osteocalcin, and that's going to reduce the amount of calcium in your bones. Some people say that cola drinks reduce the amount of calcium, maybe because of acidity. Don't buy that one. Going on, we have magnesium. Deficiencies of magnesium, pretty rare, but if you do have a deficiency, chances are you've got an inflammatory bowel disease or celiac disease or severe diarrhea or something like that. The phytoestrogens, those things like garbanzo beans and lentils, well, they're supposed to have what we call phytoestrogens. They probably have very limited effect, if any effect. And we know that frail elderly individuals need to be given a protein supplement and calorie supplement. You need enough. Now, exercise is very important. But exercise alone does not prevent osteoporosis. That is correct. Exercise alone does not prevent thinning of the bones as you get older. If you want to prevent thinning of the bones by exercise when you're 5 years old, 7, 8, 10, 15, and 20 years old. The exercise you get when you're 50 and 60 and 70 years old, that can help prevent you from falling. And that's very good. It increases the muscles, and that's very good because the muscles are a cushion to the bones, but it's not probably going to get you thicker bones. And guess what? If you stop exercising, any of the benefits that you get from exercise seem to disappear. So remember, with exercise, it's the neuromuscular function that's improved, and it should be at least 3 times a week. And interestingly, it would appear that exercise can give you all the benefits of any of the expensive drugs that we're talking about. Now, some people believe in hip protectors. Hip protectors don't seem to be all that good. There's the kyphoplasty or the vertebroplasty that we talked about a moment ago. If you happen to have a vertebral fracture one of the bones in your backbone, well, the doctors can either put a balloon in and fill it up with some of this paste or just inject the paste. And it might be okay, but it probably doesn't do nearly as much as they say, and it's associated with certain kind of complications, and some of the material can get out of the bone, and sometimes it can get into the vertebrovenous plexus and embolize, and then we have a problem. Well, estrogen. Estrogen is a very common treatment, used to be a very common treatment. Now there's the fear about estrogen increasing the risk for a variety of cardiovascular problems, breast cancer, so it's not used as much. On the other hand, estrogen certainly can help protect the bones, and as a result, it can reduce the likelihood of fractures. Can reduce the likelihood, if we talk about those numbers, we said everything is 30, 40, 50%. Well, it reduces it by about 50%. But you have to start early and you have to continue taking it, because if you stop taking it, the benefits that you get are going to be lost. But some of the studies show, for instance, the HERS study, that's the heart and the estrogen progestin replacement study that came out quite some time ago, showed that there was no effect of hormonal therapy on preventing fractures. So at least we have one study that showed that there wasn't any benefit. And then we have the Women's Health Initiative that looked at an enormous number of women, and it showed that we could, with the estrogen therapy, reduce the likelihood of hip or spinal fractures by somewhere around 30%, and all fractures were reduced by about 24%. The problem was that it could increase the incidence of heart attacks by about 30%, increase the incidence of stroke by 40%, increase the likelihood of blood clots by 100%, increase breast cancer by about 26%, and double the incidence of Alzheimer's disease. All obviously bad, but it's a small increase when we look at the actual numbers. So if you look at 10,000 women and you treat them for a year, well, yes, we're going to increase the incidence of heart disease. 8 more heart attacks per 10,000 individuals. Very small number. Same increase in breast cancer, 8 per 10,000. On the other hand, we're going to have 5 fewer hip fractures, 44 fewer clinical fractures, and probably the extra benefit is there are going to be 6 fewer cases of cancer of the colon and rectum. So that seems to be good. Why does estrogen work? Well, it works because it stops the bones from being broken down. And it has a lot to do with a series of chemicals that you never heard of. The TGF and the IGF and the interleukins and the tumor necrosis factor, all of that's very important. But the important thing is that in the long run, estrogen reduces the likelihood that the bones are going to be broken down. Well, how important is estrogen? Well, it's probably a good therapy for those people in whom the risk warrants it, but that's a very small number of people, because remember, we're increasing the risk of some other kind of problems. And if you happen to take estrogen and you have your uterus in place, then you have to take another drug, you have to take progestin, and now that can cause other kind of problems. Well, interestingly, in the hormone family, or the hormone receptor family, there are other kind of drugs, and we call them SERMs, S-E-R-M. And SERM stands for selective estrogen modulator, receptor modulator. And those drugs, principally Avista and Nolvadex, those drugs can actually help prevent bone fractures. The Tamoxifen or the Nolvadex, used typically in women who've had a history of breast cancer to prevent recurrence of the breast cancer, well, that seems to be able to protect the bones, and so too, Avista can do the same thing. Now, they sort of act either like estrogen or they oppose the action of estrogen. And they do different things in different tissues. It's tissue specific. But at least as far as the bones are concerned, they are protective. Now, tamoxifen decreases the bone turnover, decreases the bone loss. It unfortunately acts like estrogen on the uterus, and that's not such a good deal. Well, it has some risk factors associated with it. Avista, you take Avista on a regular basis, and it protects the bones basically the same as the tamoxifen. The effect on bone density is significant over a period of time. It decreases the relative risk, as I said before, by about 75%, but the absolute decrease is about 1%. increases the bone mineral density of the lumbar spine, the hip, and the total body, decreases the vertebral fracture, but probably doesn't do all that much for non-vertebral fractures. So there's question about that. Good benefit is that it'll reduce the likelihood of developing breast cancer. Well, we know that the drugs are not terribly commonly used, especially because all of the advertising has to do with drugs that we call the bisphosphonates. Now, the bisphosphonates are probably overused, the benefits are probably overstated, and the risks are probably understated. These are drugs that have that global alliance I was talking about of all sorts of people promoting them. It's a classic case, according to some, of disease mongering. It's a condition where we've transformed a risk into a disease, and the disease, of course, needs a treatment. And now we have the push for treating women who have osteopenia. And remember, we said that about half of all postmenopausal women are going to have osteopenia. Well, the bisphosphonates can be used to prevent and treat osteoporotic fractures. They can be used to treat and prevent corticosteroid, prednisone-induced osteoporosis, and they can be used to treat osteoporosis in men. Well, in order to get effective treatment, we have to have at least an increase in 4% of the spinal bone mineral density and at least a 6% increase in the hip bone mineral density. And that takes a long time. And sometimes we get it and sometimes we don't. That's why you shouldn't have a bone scan too frequently. Well, we know that if we talk about the bisphosphonates, they decrease the action of the cells that gobble up the bone. We call those cells the osteocytes. They decrease the osteocyte number, they decrease the function of the osteoclast. They actually go and kill the cells. And all that sounds good, but unfortunately, you need some of those cells to be around because they happen to put the calcium in the bloodstream, so that's a very important thing. They reduce the micro damage of the bone, and we get into an issue where the question is, how long should a person take them? And if you take them too long, because they're not able to allow the bones to heal, does that increase the risk of problems? So we have the atypical femoral fracture, where you can have some very peculiar fractures of your femur. That's the long bone in your upper leg. And now we know that you can have osteonecrosis of the jaw. That's where your jawbone actually just dies. And that can be a problem. We discovered that just in 2003. Now, for the most part, it occurs in people who have cancer, like myeloma or metastatic cancer, but it can occur in people who are just taking the standard kind of medication because they're at risk for osteoporosis. Most of the time, it's in the jaw, 2/3 of the time, oftentimes comes on after a dental extraction, and it can be entirely painless. Now, the drugs seem to be okay. Originally, when they came out, we thought that they might cause a lot of upper gastrointestinal symptoms, nausea. Well, they probably don't do all that much more than a placebo. We know that if you get an injection of the drug, if it's used intravenously, well, for 24, 48 hours after, you can get some fever and you don't feel well and you get some joint pain. It goes away. But the question is, did you really need it in the first place? And is it better to take a shot or just simply take a pill on a regular basis? And the two seem to be equally effective. Well, the drugs are very poorly absorbed. So if you're going to take them by mouth, you better take them first thing in the morning. If you're talking about a drug like Fosamax, well, less than 1% of that drug is going to be absorbed. So you got to sit upright for at least 30 minutes after you take it. You take it first thing in the morning. Take it with a big glass of water so it goes all the way down. Don't take it with anything else. Don't even take it with tea. Because if you do, it's going to significantly reduce the absorption of the drug. Better take it after an overnight fast. Now, it's important to realize that these drugs may be beneficial. But we know in a Canadian study, looking at 65,000 hip fractures, there was a 5-fold variation in the different provinces of people taking the osteoporosis treating drugs, at least in people over age 55, but there wasn't any change in the different provinces as far as the rate of hip fractures was concerned. Now we know that there are different drugs and the different drugs work a little bit differently and they have different side chains and and there's some biochemistry involved that we don't have to talk about. And the Food and Drug Administration says you ought to take them for maybe about 6 years. And probably they're going to do something for the vertebral and the non-vertebral fracture rates, but there's no rationale for taking them for your entire lifetime. That probably is inappropriate. We know the most effect you're going to get probably is in the first couple years of taking the drugs, and if you take them longer, then they probably don't work any better. We know that there's a question about the studies that were done, the randomized controlled studies, and the drugs as used in the real world. We have all sorts of stories about how drugs seem to do well. You remember some of those COX-2 inhibitors, the drugs like Vioxx that were supposedly so great they were going to prevent gastrointestinal events, and the studies showed that you could do that and save $20,000, but in reality, the cost of $20,000. But in reality, it was about $100,000, and maybe the drugs didn't even work the way they were supposed to, because we have different groups of people in the real world than we do who are in studies, who are pristine, who aren't taking a lot of medicines. Major source of difference. Now, what you have to realize is that if we take those drugs, if we take the bisphosphonates, if we take the Fosamax, if we take the Actonel, if we take the Boniva, and if we, after a couple of years, do another bone density test and we find that the person is no longer in the osteoporosis range, but maybe now is in the osteopenic range, maybe they don't have to take the drug anymore. Maybe the drug has done what it's supposed to do. Well, once you take the drug's going to stick around for a long time. If you happen to take the Actonel, it's going to stay in the bone for about 20 days. If you happen to be taking the Fosamax, it's probably going to stay in the bone for about 10 years. The drugs just came available in 1995. Remember 1994, the World Health Organization with the whole concept of the bone mineral density and the minus 2.5 standard deviations? Well, guess what? It may well be that there is a correlation. Well, it's important to realize that if we talk about vertebral fractures are not life-threatening for the overwhelming majority of people. Drugs probably are effective. If we look at people who are most likely to suffer from hip fractures, those are people who are old. Average age in the United States, 80. Well, are the drugs helpful in people who are 80 years of age? And the answer is, it doesn't seem that the drugs are very effective in women who are older if we're talking about prevention of hip fractures. And it doesn't make any difference which of those medicines that we're talking about. Well, now we can take the drugs either orally, once a day, or we can take them weekly at 7 times the dose, or we can take some of them by injection. And the question is, do they work? They all seem to work about the same. There's the concept that we can use some of the drugs, and we can use the drugs interchangeably. Well, the drugs all do something a little bit different. The mechanism is a little bit different, just a little bit different, but it is different. Then there are some other kinds of medicines. So we have one called Prolia. Prolia is a monoclonal antibody. This is a monoclonal antibody that actually works to go and prevent the bone from breaking down. So that's kind of a good idea. It prevents the bone from breaking down because it prevents a chemical on the osteoblast, the cell that makes the bone, and that chemical stimulates the production of the cell that breaks the bone down. Well, the Prolia goes and blocks that. So we don't get the osteoclast formation, and that's good. But unfortunately, there's an increased incidence of hospitalization for infection. We have eczema, we have a significant problem with decreased calcium, and we have osteonecrosis of the jaw and the atypical hip fractures, atypical leg fractures. This drug is injected twice a year, injected in the area immediately underneath the surface of the skin, and it seems to work. It seems to do what it's supposed to do. And it's an expensive drug. It costs about $2,000 a year. That's better than Forteo. Forteo is the Tairy Peptide, and that is the parathyroid hormone agonist that was approved in 2002 it seems to actually stimulate bone formation. So that's very good. Unfortunately, at least in rats, it can cause a bone tumor, a tumor called osteosarcoma. So if a person has Paget's disease or a person has increased alkaline phosphatase, probably not a good drug for you. And as I said, the drug is extremely expensive. So the question is it worth it? And for the overwhelming majority of people, we have to consider other than drug therapy. We should consider other mechanisms first. And then afterward, then we should consider drug therapy. And we should consider the least expensive drug therapy as equivalent in many respects to the most expensive drug therapy. Well, with that, I hope you've learned something about osteoporosis. I hope you've learned that there's a lot of controversy about osteoporosis, about the diagnosis, about the treatment. There's a lot of question about the impact on direct-to-consumer advertising available here in the United States, but not if you go to England, not if you go to Canada, not if you go to the Scandinavian countries. It seems that we allow the advertising here, and unfortunately the advertising oftentimes portrays semi-truths. Sometimes you don't get the full picture from the ads that occur on the television. And unfortunately, sometimes those not complete truths filter out into your doctor, and then you get the therapy that might not be for you. I thank you for watching. Be on again soon. Take care now. I'm Dr. Ken Landau.